Chalo. So I hope all of you guys are doing great, and this will be one of the very important session for the upcoming examination that we have. This topic, TB and malaria, I'm sure all of you guys are aware about the fact this is one of the very important topic, and in every examination, be it NEET PG, FMGE or INIC, there are definite questions that are going to be asked from these areas. Okay, I was not aware actually. Chalo. So let's get started with this batch, that is, the today's session, where we'll be talking about anti-tubercular and anti-malarial drug. Okay, so first and foremost thing that I'll be talking about in the anti-tubercular drug, that do you guys know that in the tuberculosis we are having two important areas. One is known as your drug sensitive tuberculosis, and other one is known as your drug resistant tuberculosis. Drug sensitive and drug resistant TB. According to National TB Elimination Program, that is the new guideline 2020 May it was launched, NTP 2020. Do remember few important points has been highlighted, and what are those few important points that I want all of you guys to remember at any point of time? One is to decrease the duration of the therapy. There should be decrease in the duration of the therapy. Okay, decrease the duration as compared to earlier where the treatment was for 2 to 3 years. Now we have lesser duration, 6 to 9 months, 9 to 12 months, and the longer regimen is barely for 18 months. Then promote oral drugs, no injectables, the oral drugs that we have, no injectables. Now this is all going to increase the compliance of the therapy. Drug sensitive tuberculosis remains the same. We are having a 6-month course in the drug sensitive tuberculosis, which will be further divided into intensive phase of 2 months, where we are going to use the same drug HRZE that we have been using since ages, Ison Acid, rifampicin, pyrazinamide and ethambutol. And the continuation phase that we have, that is given for a duration of 4 months, we will be using HRE, Ison Acid, rifampicin and ethambutol. Right, so there is no rocket science in this one. This is going to be same. Now the major changes that we have seen in the tuberculosis is mainly in the drug resistant tuberculosis. Okay. How are we going to proceed? Let me just quickly give you an idea. I'll be quickly discussing this TB and malaria, and then I'll be having a quick quiz as well on the same topic, so that everything that has been asked in the recent examination will be covered, and the upcoming question that could be asked, right, we have also included in our today's course, okay, in our today's session. So I hope all of you guys will enjoy, and you will end up solving all the TB and malarial question correctly in your examination. Okay. Drug resistant tuberculosis will be further subdivided into two important areas. One is known as your MDR TB, multi-drug resistant TB, and other one is known as your XDR TB, extensive drug resistant TB. First and foremost, the definition is very, very important for all of you guys. What are the definition for MDR TB and XDR TB? MDR TB, it is the same definition that we have, that there should be resistance with Ison Acid and rifampicin. This has been asked in 2021 NEET PG examination, but in FMGE they have asked little difficult kind of question. The definition of XDR TB. So what is the definition? Again, there will be resistance usually with Ison Acid and rifampicin. H and R is same. Resistance also with any one fluoroquinolone. Earlier we were using that, okay, there should be resistance with the any one second line injectable, but since we are not using injectable, we are using oral. So if this is not there, then or there should be resistance with the bedaquiline, the newer anti-tubercular drug. Bedaquiline is one of the ATP synthase inhibitors. So either there should be resistance with any one second line injectable, or bedaquiline se resistance hai, then we will be calling it as a XDR TB. Okay. Now what are the treatment therapy that we have for the drug resistant TB? Remember, we are using shorter regimen, and there is one longer regimen as well. Let me quickly just go through these important regimens. We are having short regimen, and we are also having long regimen. The shorter regimen for tuberculosis that we have, there are two. One is for inpatients. The one that is for inpatient is actually for 6 to 9 months, and there is one more that is 9 to 12 months. Okay. So in between 9 to 12, it can be 9, in PARC they have mentioned 9 to 11 months, so it's 9 to 12 months or 9 to 11 months also you can consider. Longer regimen, it is given for 18 months. Imagine the XDR TB which was receiving earlier, the patients were receiving therapy for 2 years or expandable up to 2.5 to 3 years. Now in 18 months things will be covered. 6 to 9 months it is mainly for inpatients and for all our OPD patients. जितने भी OPD patients are, they will be receiving this 9 to 12 month वाला therapy, and this will be for all the OPD patients. ठीक है. There are certain conditions where are we going to use the longer regimen, that I will be talking subsequently. I think this much is okay here. टोटल ड्रग रेजिस्टेंट में तो अगेन सारे रेजिस्टेंस है ना, तो उसमें वी डोंट हैव मच ना say in that. All we need to do, we give the supportive therapy. So let me just talk about shorter regimen. We are having two shorter regimen. One is for 6 to 9 months, and in this one we are going to use B-Pol regimen. B-Pol regimen is bedaquiline, pretomanid and linezolid. Just remember this bedaquiline, pretomanid and linezolid that we have. Quick question on this topic. What could be the upcoming examination question? What is the mechanism of action of bedaquiline? So just remember B for bedaquiline, it is one of the ATP synthase inhibitor. B and A, ATP synthase inhibitor is bedaquiline, and these are cidal in nature. Then we are having pretomanid. It is from the family of already existing drug by the name of delamanid. So be it delamanid or pretomanid, they both are ending with the manid and manid. So this manid wali drug that we have, remember, these are mycolic acid synthesis inhibitor. You can expect one question either on these drugs. Mycolic acid synthesis inhibitor, these are also going to have a cidal effect. So manid and manid, mycolic acid, ATP synthase inhibitor will be bedaquiline. Okay, linezolid is a protein synthase inhibitor, which you all are aware already. Then the one that is utilized for most of the patients, those who are visiting in the OPD, will be 9 to 12 month therapy. That will be your divided into further intensive phase of 4 to 6 months, intensive phase of 4 to 6 months, and continuation phase of another 4 to 6 months. Okay, intensive phase mein we are having 7 drugs. Remember, we are having 7 drugs here. Now what are those 7 drugs? That is important for you. Okay, important for you to remember. All of them are given on the daily basis. These are all given on the daily basis. Okay, now these 7 drugs that we have, these are bedaquiline, ethionamide, Ison Acid, high dose of Ison Acid, and we are going to use clofazimine, levofloxacin, ethambutol and pyrazinamide, right? So Baycleb, this is a very simple mnemonic to remember. Baycleb, all of you are already aware about your base, right? And I'm pretty sure that you have your own base, and your bay will have a spelling of BEE, BAE, Bay, babes, right? But in pharma we call, remember, it as a BEI. थोड़ा abnormal सा है, adjust कर लीजिए. And too much adjustment नहीं हो सकता, so I will not be continuing with such bay जिसका नाम ही गलत है, BEI. हम continue नहीं करेंगे. Bedaquiline, highly cardiotoxic drug. Remember, ethionamide, Ison Acid, high dose of Ison Acid will be showing cidal effect, right? So we will not continue with such bay. I will continue only with the CLEP, right? I will continue only with the CLEP, that is your clofazimine, levofloxacin, ethambutol and pyrazinamide. So this was your OPD based therapy, and number of questions that has been asked here on the basis of number of drugs, that is how many drugs are used. So 7 drugs in the intensive phase and 4 drugs in the continuation phase, right? 7 and 4. Just hold on a minute please, there is some problem with the charging. I'll just be back. Okay, moving forward, we have the longer regimen, right? That is for 18 months, which will be divided intensive phase for 6 months, continuation phase for 12 months. So 6 plus 12, totally it will become 18 months. We are having 4 drugs in the intensive phase. That will be 3 drugs from category A, and you can remember with the simple mnemonic, category A drugs are LLB wale drugs. LLB drugs are category A, linezolid, levofloxacin and bedaquiline, and 2 drugs are there in the category B. Out of these 2 drugs, any one will be utilized. Cycloserine, clofazimine. Out of these two, any one will be utilized. So total number of drugs, if you are going to see here, there will be 4 drugs only. 3 drugs from category A, linezolid, levofloxacin and bedaquiline, and any one from the category B. Remember, as I told you previously as well, that bedaquiline is a cardiotoxic drug. We will not be using them. They are also having other side effects like hepatotoxicity. They are also causing electrolyte imbalances, and so we will not be continuing beyond 6 months. So we are going to continue with linezolid, levofloxacin, either cycloserine or clofazimine. दोनों में से कोई एक. Again, on the basis of number of drugs, you can easily remember. For the OPD patient, we had 7 drugs in the intensive phase, 4 drugs in the continuation phase. For longer regimen, we are having 4 drugs in the intensive phase, 3 drugs in the continuation phase. Now, who are the candidate? Who are the candidate? Those who are going to receive the longer regimen? If we already have the shorter, why longer? So, for all the extensively involved lung parenchyma patients, right, if there is a extensive lung parenchyma involvement, we can utilize this one specifically for XDR, lung parenchyma involvement, like if there is a patient with the bilateral cavitation, if there is a extensive extrapulmonary TB, if there is a pediatric population less than 6 year mein, in pregnant female as well, we can use it. And the most important here, if someone has taken the therapy, patient has taken the treatment for more than 4 weeks, patient has taken the therapy for more than 4 weeks and stopped. ऐसे पेशेंट्स जो 4 हफ्ते से ज़्यादा या 1 महीने से ज़्यादा ट्रीटमेंट लेकर के स्टॉप कर दिए, ऐसे पेशेंट में वी विल बी प्रिफरिंग द लॉन्गर रेजिमेन, राइट. सो लॉन्गर रेजिमेन अगेन इट विल बी हैविंग 4 drugs and 3 drugs respectively. Quickly, one more important information that I can add on here in this session will be the important drugs under the first line and what are the important questions that has been asked from here. This table is going to give you definite one question in the examination where we are going to talk about the first line drug Ison Acid, rifampicin, pyrazinamide, and now I am going to call just for the day pyrazinamide as pyrazinamide and ethambutol. Remember, we have one more drug, streptomycin. This was earlier used as a first line add-on drug, first line injectable drug. Now we are not using them. It's not under our NTEP protocol, right? NTEP जो treatment regimen है, उसमें we do not have streptomycin, or in fact any aminoglycosides are not there, because they are promoting all oral, है ना. So, but when you solve the older MCQs, you will be getting questions on this. First and foremost, what are the doses that we have? Ison Acid ka we have the dose 5 mg per kg. Rifampicin is this is on the basis of milligram per kilogram. Rifampicin 10 mg per kg. Pyrazinamide it will be 25 mg per kg. Ethambutol 15. Streptomycin is also 10 to 15. So first and foremost thing that you should remember, that pyar ka dose you have to keep always and always high. Pyrazinamide is always kept high, so their dose will be maximum among all of them. Let's talk about the mechanism of action. Important mechanism of action for Ison Acid that we have. Remember, it is one of the mycolic acid synthesis inhibitor. Mycolic acid synthesis inhibitor. The name of the drugs that I am talking about here will be your Ison Acid. Now this Ison Acid is actually being a prodrug. It will be activated with the help of an enzyme by the name of catalase peroxidase. This enzyme catalase peroxidase, normal activity of catalase peroxidase is very much important for the activation of Ison Acid, and this active Ison Acid is the one that is going to actually inhibit this mycolic acid, or it will be targeting mycolic acid synthesis. It will be inhibiting the mycolic acid ka synthesis. Okay, I think I am fine now. The audio is good now, I believe. कुछ तो प्रॉब्लम हो रहा है. Something or the other is getting stuck. अभी ठीक है. Am I audible and visible now? Sorry for the short interruption. कुछ I don't know what was happening. All good? Okay. So as I was telling to all of you guys that Ison Acid, it is one of the drug that is going to get activated by catalase peroxidase, one of the enzyme from the microbes that we have. Okay, now do remember this activation of catalase peroxidase or catalase peroxidase is an enzyme that we have. The name of the gene will be CatG gene. What is the name of a gene that is activating this one? The name of the gene is going to be your CatG gene. It is this CatG gene encodes the enzyme known as your catalase peroxidase. ठीक है, CatG gene encodes catalase peroxidase, which is going to be involved in the activation of Ison Acid, and whenever the Ison Acid will be activated, they will be causing cidal effect on the mycobacterium. Next thing that you should know, rifampicin, R for rifampicin, it is one of the RNA polymerase inhibitor. RNA polymerase. Since this RNA polymerase is dependent on the DNA, the full name is DNA dependent RNA polymerase inhibitor. So this table is having lot of information, DNA dependent RNA polymerase inhibitor. Pyrazinamide that we have, as I was calling it as a pyrazinamide, a couple of times I have called it already, pyrazinamide. Try to understand this pyrazinamide, it is also one of the mycolic acid synthesis inhibitor. This is also one of the mycolic acid synthesis inhibitor. Like pyar, it is also going to target from inside. जैसे प्यार अंदर से मारेगा, ये भी अंदर से मारेगा. What do I mean by that? Let's understand that this pyrazinamide that we have, pyrazinamide as a drug that we have, it enters the cell, and inside the cell they will be activated with the help of an enzyme known as your pyrazinamidase. This pyrazinamidase as a drug that we have, it will be activating this drug pyrazinamide, and once they get activated, where are they getting activated? Inside. So this is one of the drug that is exclusively effective intracellularly, right? Once they become active again, they will be targeting your mycolic acid synthesis, and ultimately they will also be having cidal effect. Our RNA polymerase inhibitor rifampicin, it is also going to have cidal effect. Next that we are having is ethambutol. That is one of the, I hope things are fine now, कुछ issue तो नहीं है? Hi guys, is it stuck or it's okay? Okay, thank you. Now let's talk about ethambutol. It is one of the arabinosyl transferase inhibitor. And this arabinosyl transferase inhibitor, remember, once it is inhibited, there will be no polymerization of arabinoglycans. And because of that, they will have a static effect. They are going to have a static effect. So first and foremost, remember, mycolic acid synthesis inhibitor going to act by inhibiting from inside will be pyrazinamide. Ethambutol, thum jana is ruk jana. Thum jana is a Hindi term for ruk jana. It is one of the arabinosyl transferase enzyme inhibitor, and they will be showing static property. So the one that is having static property, it will be none other than your ethambutol. Streptomycin, remember, it is a protein synthesis inhibitor. It's an aminoglycoside, a protein synthesis inhibitor targeting the 30S ribosomes. Okay? And they will also be having cidal property. So most of the drugs in the first line that I have discussed with all of you guys, it is going to be cidal, except the one that is ethambutol, that is having static property. Now as I have already mentioned to all of you guys, which one is working from inside? Pyrazinamide. Pyar is killing from inside, intracellularly. Streptomycin, remember, streptomycin, strip outside, so it is exclusively effective for extracellular bacilli, and rest of the others will be effective on both the sides, intracellular and extracellular, on both the sides. If you look at the hepatotoxic profile, like I told you, pyar is very, very toxic. So definitely the most hepatotoxic will be your pyrazinamide. Your isoniazid and rifampicin, they are also going to be hepatotoxic, but if you compare the hepatotoxic profile of pyrazinamide, that is the max. Drugs like your streptomycin, ethambutol, they are mainly toxic to renal tissue, not for the liver tissue. No drug is 100% safe for the pregnancy, but if you want to talk about PAR, remember I would say avoid PAR during pregnancy. Streptomycin, I said always and always contraindicated. All the aminoglycosides are contraindicated, in fact in pregnancy. As I said, no drug is 100% safe, but relatively these can be safer. They are considered relatively safer drugs. Mutation gene that can cause the resistance, quickly we can revise this part as well. Remember your isoniazid, it is mainly due to CAT-G gene mutation. This CAT-G gene mutation will be leading to resistance of the isoniazid, CAT-G gene mutation. RPO-B gene mutation, it can lead to rifampicin. Then PNCA gene, it will be causing resistance of the pyrazinamide. Then we are having ethambutol, this will be EMB-B gene. Ethambutol, remember, EMB-B gene. Last will be aminoglycoside that is going to get resistance because of the RRS gene mutation, RRS gene mutation. So this gene mutation has already been asked. In fact, in 2021 NEET PG also they have shown you one image and they ask you that which of the following drug required the help of, and the name of the enzyme was catalase peroxidase. Which of the following drug required the help of this catalase peroxidase? Hai na? So same, I mean topic pe multiple time similar kind of question has been asked. So if you have the basic idea, I am pretty sure you will be able to ace all these questions, right? So very simple table that I have given to all of you guys, and I will be sharing the PDF of this one in your all in our all Telegram groups that we have, so you can have a PDF of this. You don't have to worry about it. Now there was one question on INICT May 2022, which of the following ATT act by inhibiting mycolic acid synthesis by the need of catalase peroxidase? So I think this is the question that I was mentioning, which drug require catalase peroxidase? So we have isoniazid, it require catalase peroxidase. One more question that was asked in the recent examination, which of the following is a tuberculostatic? Which of the following is tuberculostatic? Now in the first line we have seen there was one drug that was coming under the list, tuberculostatic list. The name of the drug was ethambutol, but that was not the only drug that is tuberculostatic. There are other second line drugs also. So I used to tell you that do remember the drugs that are tuberculostatic among second line para amino salicylic acid. Then we are having ethambutol. Ethambutol is the only one from the first line drug. Then we are also having one more drug, that is ethionamide, ethambutol, ethionamide, cycloserine, thiacetazone. These are the drugs that we have which are tuberculostatic in nature. Out of them, the only first line drug is your ethambutol. You can remember them very easily: tuberculostatic, P, static, P, very good relation, you can understand all of you. P, CT, static, P, CT, है ना, tuberculostatic. These all drugs are tuberculostatic. And one more important information that I would like to add on to this information to yours, that will be important side effect of these anti-tubercular drugs. Quickly let us revise our drug isoniazid. It is one such drug that is getting metabolized by acetylation. And isn't that you all are aware that any drug that is metabolized by acetylation can cause drug induced lupus? वो तो एक side effect है. If there is a slow acetylator, there will be increase in the risk of toxicity. Fast acetylator, decrease in the efficacy. This information also should be known to all of you. They will be causing side effects like peripheral neuropathy, xerostomia, psychosis. They can also decrease the seizure threshold. There are studies that are telling that they can decrease the seizure threshold and therefore they can be epileptogenic in nature. So if there is already a patient with a history of epilepsy, we should avoid this drug as well. Okay, why peripheral neuropathy? If the examiner asks you why peripheral neuropathy, anyone can tell me? There are two reasons for you to know why peripheral neuropathy. One is isoniazid inhibits the vitamin B6 ka activation. They inhibit the vitamin B6 ka activation to pyridoxal phosphate. So vitamin B6 is pyridoxine. it will be inhibiting the activation to pyridoxal phosphate, that is one. Second reason, that Ison acid, it promote vitamin B6 का excretion. They promote vitamin B6 excretion. To avoid this problem, what do? We add pyridoxine with the Ison acid. So with all the first line drugs, we always add pyridoxine as the drugs. What are the reason? There are two reasons that I have explained to all of you guys, that is adding on to the peripheral neuropathy of Ison acid. Then we have a harmless kind of side effect are for rifampicin, red orange urine discoloration. They can also lead to flu-like symptom and hepatotoxicity. They can also cause hepatotoxicity, although the hepatotoxicity is lesser than your pyrazinamide. This will be relatively a harmless kind of side effect. Pyrazinamide, hepatotoxicity, as I told you, maximum hepatotoxicity among the first line drugs, and hyperuricemia, that means it can also precipitate gout. So there are 5 important reasons why am I calling pyrazinamide as a pyrazinamide. Reason number 1 that I told you, that no matter what happens in the life, you have to keep the dose of pyr always high. So maximum dose, imagine Ison acid, rifampicin, we are giving 5 to 10, but pyrazinamide it is given 25, है ना? So maximum dose, pyr का dose high. जैसे प्यार अंदर से मारता है, this will also be killing from inside, acting intracellularly. Do remember the drug that is acting by intracellular will be your pyrazinamide. Avoid pyar during the pregnancy. Okay, most toxic, प्यार बहुत टॉक्सिक है. मैं लीवर की टॉक्सिसिटी की बात कर रहा हूँ, राइट? प्यार बहुत टॉक्सिक है. एंड फिफ्थ थिंग, प्यार दर्द भी देगा. कौन सा दर्द? गाउट वाला. इट विल बी गिविंग यू अ पेन ऑफ गाउट, दैट मीन्स इट कैन प्रेसिपिटेट द गाउट. This is not the end. Examiner even ask one more question. What all drugs can cause hyperuricemia or can precipitate gout? So in addition to this pyrazinamide, ethambutol, remember, it can also precipitate gout. It can also increase the level of uric acid level, and it can also precipitate gout, in addition to the side effect like optic neuritis leading to red-green color blindness. A repeat question already. Streptomycin is aminoglycoside, ototoxicity, nephrotoxicity, neuromuscular blockade. These are the important side effect. ठीक है? I hope all of you guys are okay here, and this is one of the very important table. 2 tables I have given you. One table is this one and one table is this one. If they are going to ask you a question, you will be able to solve. This is one of the AIMS 2020, the last AIMS before it was merged to INICET, tuberculostatic, and answer was thiacetazone. If you are solving PYQ, you must have seen this question already. In the second line drugs, ethionamide, it can lead to hypothyroidism. Then next question, which other drug can cause hypothyroidism among anti-tubercular drugs? See, there are so many drugs that can cause hypothyroidism, like your drugs like imagethon can also cause hypothyroidism, है ना? This drug ethionamide can also cause hypothyroidism. Sodium nitroprusside can also cause. But in the anti-tubercular drug, they ask 2 drugs that can cause hypothyroidism. It can be associated with para-aminosalicylic acid, PAS, para-aminosalicylic acid. Do you remember, para-aminosalicylic acid is the first ever anti-tubercular drug that was found. Because of the more and more resistance, now it has been it was not used for a couple of in between. Now it has been reintroduced as a second line anti-tubercular drug. Cycloserine, neuropsychiatric symptoms. So नाम में ही देखिए सब कुछ है जो आपको साइकेट्रिक बना दे. दैट इज द काइंड ऑफ सेरीन दैट वी आर टॉकिंग अबाउट. साइक्लोसेरीन, साइकसेरीन, इट विल बी मेकिंग यू साइकेट्रिक, न्यूरोसाइकेट्रिक सिम्टम. Para-aminosalicylic acid, body secretion discoloration. Now this question, whenever it is asked, the first option that students always look for is rifampicin. Imagine if rifampicin is not there, red orange urine discoloration, body secretion discoloration. If rifampicin is not there, don't be disheartened. Look for the para-aminosalicylic acid. They will be causing body secretion discoloration, eye and skin discoloration, and most important, they will also be causing hypothyroidism. That I told you, hypothyroidism among anti-tubercular drug are 2. One is ethionamide, para-aminosalicylic acid. Repeat with me. Which drug will be causing hypothyroidism? Ethionamide, para-aminosalicylic acid. Which drug can precipitate gout? I told you gout, दर्द है ना, तो याद रखना प्यार दर्द भी देगा, and ethambutol. Okay. Linezolid will be causing important side effect like bone marrow suppression, peripheral neuropathy, and they can also add on to serotonin syndrome. Betaquiline, ATP synthase inhibitor, delamanid, mycolic acid synthase inhibitor, they both are known to cause QT prolongation, and they can even lead to your hepatotoxicity, right? They also can cause hepatotoxicity and electrolyte imbalance as well. Okay, so I hope all of you guys can grab most of the important questions from these areas that has been asked. Let us do a couple of questions. Very simple question. This is one of the recent NEET PG question. Patient was started on ATT drug. He is having tingling. So can you not able to do this? I mean, this question has been asked in the past. Same चीज है, like the same questions are being asked. Which drug is going to cause peripheral neuropathy? Same first one line drug को क्या किया, one line question को क्या किया? They have made it in a form of case. So now you know peripheral neuropathy can present with tingling sensation, numbness, है ना? Peripheral neuropathy. So deficiency of which of the following? Vitamin B6. As simple as that. NEET PG 2022, as I said, MDR TB का definition has been asked. Ison Acid rifampicin will be the correct answer for this question. Okay. Now, since the time is running out, I would like to take quickly malaria as well, and then I am having 10 to 12 MCQ for all of you guys. Just try to solve that at the end of everything, है ना? अभी मैं उसको आपको solve करा के ही जाऊँगा. In the malaria, see, if there is a chloroquine sensitive, give chloroquine. As simple as that. कोई doubt नहीं. If there is a chloroquine resistant, then we are going to use artemisinin combination therapy, which is ACT, artemisinin combination therapy. One more thing that you should know, that this artemisinin combination therapy will be given on the basis of patient कहाँ से आ रहा है. If the patient is coming from the northeast state, then we are going to use artemether plus lumefantrine. AL means A for your artemether. Artemether, it is one of the artemisinin compound. Artemether. L for your lumefantrine. ठीक है. So नॉर्थ ईस्ट स्टेट छोटा स्टेट है, दो ड्रग में काम चल जाएगा. जस्ट रिमेंबर, नॉर्थ ईस्ट स्टेट छोटा स्टेट, दो ड्रग है ना, दो ड्रग. NE में हम क्या यूज करेंगे? AL, artemether lumefantrine. And if the patient is coming from rest part of the India, then preferred drug will be your artesunate, one of the artemisinin compound, artesunate and sulfadoxine pyrimethamine. Artesunate, sulfadoxine pyrimethamine. So again, rest of the India will be much longer. So the 3 drug regimen will be used for rest of the India. Always remember, sulfadoxine pyrimethamine, they are never used alone. They are always used in combination, because alone they will be static in nature, together they will become cidal. Okay, one is folic acid synthase inhibitor, other one is the dihydrofolate reductase inhibitor. Can you tell me which one is synthase inhibitor? S for synthase inhibitor, and P wala jo drug hai, that will be pyrimethamine. It is one of the dihydrofolate reductase inhibitor. In addition to both of them, we are also going to add a very important drug, that is primaquine. ये प्रेम से मलेरियल पैरासाइट को ख़त्म करता है, प्राइमाक्विन. नाउ प्राइमाक्विन, इट डिपेंड्स कि हम किस कंडीशन में यूज़ कर रहे हैं. इफ़ इट इज़ फैल्सीपैरम मलेरिया, देन प्राइमाक्विन विल बी यूटिलाइज 45 मिलीग्राम सिंगल डोज ऑन डे 2. सेकेंड डे ऑफ थेरापी पे वी कैन यूज. But if the examiner is going to ask you for the Vivax or for the oval malaria, we will be using chloroquine with the primaquine. If there is further resistance to chloroquine, can we use artemisinin combination therapy, this ACT? Yes. If there is a resistance again with the chloroquine, in Vivax also we can use artemisinin combination therapy. But for now, you should know that chloroquine is sensitive and we are using them. They are the preferred one. And what you should know, that primaquine in this case scenario will be utilized 15 milligram on the daily basis for a total duration of 2 weeks, because we need a radical cure. Radical cure is mainly required in this one. If you read carefully the life cycle of this malarial parasite, so then you will be able to understand that some parasite, they are forming hypnozoid, they are hiding themselves, causing the recurrent infection, right, recurrent cause of malaria. Therefore we need to do radical cure for these parasites. Severe malaria, other term that can be used will be cerebral malaria, other term they will be using will be complicated malaria. For all of them we will be using IV artesunate. IV artesunate will be utilized, है ना. So one question that is being repeatedly asked, a patient from Assam, है ना, ये क्वेश्चन बार बार आता है, पेशेंट फ्रॉम आसाम, पेशेंट फ्रॉम नॉर्थ ईस्ट स्टेट. सो कहीं से भी आ रहा है, इफ देयर इज अ सेरेब्रल मलेरिया, अ पेशेंट विद द लॉस ऑफ कॉन्शियसनेस, यू यूज IV थेरेपी एंड आफ्टर दैट यू wait for some time, let's say in a 48 hours. If the patient regains consciousness, then you can shift back again to per ORM artemisinin combination therapy with the primaquine. Do remember primaquine, I am repeating again, for the Vivax and Oval we are using for 2 weeks, and for your falciparum single dose on day 2. If there is a pregnant female, this is another question that is being very frequently asked. Falciparum malaria की बात अगर होगी, then quinine with clindamycin. In the first trimester we avoid artemisinin group of drugs. Not in human model, but in animal model they have studied. In the animal model they have studied that it is causing some cardiac related teratogenic effect like ventricular septal defect. Which one? Artemisinin group of drug, है ना. So first trimester में we are using quinine with clindamycin. Black water fever, Dr. Zoom, is associated mainly with the quinine, है ना. Quinine is associated with the black water fever. So first trimester pregnancy, quinine with clindamycin. Second, third trimester में we can use artemisinin combination therapy. Again remember, primaquine is contraindicated in pregnancy throughout. Primaquine is contraindicated. If it is Vivax malaria, then we are going to use chloroquine 300 milligram on the weekly basis, right. Initially loading dose हम देंगे 600 milligram, then 300 milligram on the weekly basis throughout the pregnancy we will be giving. Remember, primaquine here also it's contraindicated. A question that is being frequently repeated is on the prophylaxis. When the patient is traveling to malaria endemic area, if the duration of journey is less than 6 weeks, then we will be giving doxycycline 100 milligram on the daily basis. If the duration of journey is more than 6 weeks, we call it as a long-term prophylaxis. We are going to use mefloquine. We are going to use mefloquine 250 milligram on the weekly basis. Doxycycline 100 milligram on the daily basis that we have. When are we going to start? It will be started 2 days prior to the journey and should be continued till 4 weeks after. Mefloquine, it is given on the weekly basis. So again, before the journey the patient should take at least 2 doses. So it will be started 2 weeks prior to the journey and should be continued till again same 4 weeks after. So after the journey in both the scenario, 4 weeks after, it is going to be same in both the scenario. But the short term prophylaxis, it will be started 2 days prior. Long term prophylaxis started 2 weeks prior, and after the journey दोनों ही कंडीशन में 4 weeks after तक we need to continue, right. So this was a quick very summarized table for the malaria for all of you guys. I think I have told you already this one for falciparum, northeast state wala, and rest of the India say what are we going to use. We have discussed this already. On day 2 single dose of primaquine we will be using. Okay. Malaria in pregnancy also I told you, if it is Vivax, chloroquine 300 milligram, falciparum or mixed infection में we are, mixed infection means there should be a combination of both Vivax plus falciparum. Is it possible? Yes. In that scenario, quinine plus clinda in the first trimester, and second, third trimester में we will be using artemisinin combination therapy. What is never used in pregnancy, primaquine is not preferred in the pregnancy. Okay. A couple of more questions that I can highlight here. For the radical cure we will be using primaquine, and one more thing that we will be adding here, that one of the congener of the primaquine that we have is a very tough drug by the name of tefenoquine. Do you know why it is tough drug, or I usually used to say also it's a tufani drug. Why is it very tufani? Tefenoquine is a tufani drug because this tefenoquine, it is a congener of the primaquine. It has a high volume of distribution. Because of the high volume of distribution, the T half-life is usually around 14 days. If you see primaquine in oval, it is given for 14 days. Tefenoquine as a single dose में ही it can cause a radical cure. In a single dose में ही it can cause a radical cure. So that is why I say it's very tufani drug, no? single dose is enough, right? It is causing the radical cure in a single dose. Okay, so tafenoquine, it's a very, very tough drug. It's a conjugate of the primaquine. Fastest acting anti-malarial drug, that is artemisinin, that is acting by free radical generation, है ना? Free radical generation, artemisinin. Artemisinin, remember, is derived from traditional Chinese medicine, TCM, है ना? Artemisia tree से derived drug है ये, ठीक है. न्यूरोसाइकेट्रिक मेफ्लोक्विन मूड खराब कर देता है. एंड इन द ट्यूबरकुलर ड्रग आई टोल्ड यू साइक्सेरिन, साइकेट्रिक बना देने वाला साइक्सेरिन. हेलोफेंट्रिन causes QT prolongation and remember hemolysis maximally with the primaquine. I have told you already. Last question that has been asked once in FMGE, what is pyronidine? Options had antiviral, antifungal, antitubercular drug, so or anti-malarial drug. So remember, it's one of the anti-malarial drug. Pyronidine, as the word is saying, pyrigesic. So it is the anti-malarial with the analgesic property. Anti-malarial with the analgesic property. The name of drug is pyronidine. Okay. So this was a very quick revision of the malaria. A couple of more data that I can add on here, like chloroquine. It's a rapidly acting erythrocytic agent. Rapidly acting. So it's one of the fast acting drug. An erythrocytic agent. Right. Chloroquine. Which drug have no effect in the erythrocytic stage? Remember, primaquine is one such drug. Primaquine, it is not effective in erythrocytic stage. तो ये भी एक बहुत potential MCQ है. Not effective in the erythrocytic stage. तो कौन से stage में effective होगा? If it is not effective in erythrocytic stage, it will be usually effective in your exoerythrocytic stage and gametocytic stage. For the gametocytic purpose we can use, and as an exoerythrocytic also we can use, but not for the erythrocytic. Okay. Indication of chloroquine that we have, remember, it is not only used in malaria, it can be utilized in multiple conditions, and all those conditions you can remember by the mnemonic PREM-DIL, PREM, PREM-DIL. So I think primaquine, काफ़ी सारा प्रेम की बात हो रही है ना आज. Primaquine is again, I told you, प्यार से वो मलेरिया को किल करेगा, है ना. So PREM-DIL will be photogenic reaction, rheumatoid arthritis, extra-intestinal amoebiasis, malaria, discoid lupus erythematosus, which is a variant of SLE, infectious mononucleosis, and type 2 lepra reaction will be also we can use, which is also known as your erythema nodosum leprosum. So these are the different indication of your different indication for chloroquine. And one last thing about chloroquine will be the side effect. So the most common side effect will be gastritis, which is considered the most common side effect. Other side effect could be rash, ototoxicity, oculotoxicity, and they will also be causing your bullseye maculopathy. Do remember this bullseye maculopathy that they are going to cause, it's an irreversible response. Okay? They can even lead to dizziness, nausea and vomiting. Hypotension can also cause your QT prolongation. Okay? So group depresses my heart. When I am staying in a group, it depresses my heart. Just a way to remember that chloroquine में group depresses my heart. So यहाँ पे आपका हो जाएगा gastritis, rash, ototoxicity, oculotoxicity, peripheral neuropathy, myocardial depression that can lead to fall in blood pressure, QT prolongation, and hemolysis, especially in G6PD patients. ठीक है. That is why G6PD में chloroquine, primaquine ये सारे drugs हम क्या करते हैं, नहीं देते हैं. Last question. It is the contraindications of chloroquine. It is contraindicated in these areas. What are areas in which they are contraindicated? G6PD. Why G6PD में they are contraindicated? Any ideas? Any guesses? Because they are causing hemolysis. Then other contraindication can be antacid, because in antacid we are having aluminium and magnesium that will decrease the absorption, and also in psoriasis or porphyria also they will be contraindicated. So GAP is a simple mnemonic in which you can remember chloroquine is going to be contraindicated. So this was a very quick summary of TB and malaria. Let us see if you guys are able to do the questions that had been asked on the basis of this, or that could be very potential MCQ. So this is one expected MCQ for all of you guys. According to recent update in MDR tuberculosis guideline, shorter drug therapy regimen of 9 to 12 months include. It's your turn to give me the answer now. If you have been listening to me carefully, not doing anything, simply sitting and putting your headphone in the ear and listening to me carefully, you can easily mark 7 drugs in the intensive phase, 6 drugs in the continuation phase, 7 in intensive, 4 in continuation, 6 in intensive, 4 in continuation. According to NTP के बारे में बात करना है आपको. because only in NTP we have 9 to 12 month वाला regimen. So what's your answer? I told you BE के साथ CLEP, BEI, bedaquiline ethionamide and isoniazid high dose. I will not continue with such BE. So BE CLEP will be 7 drugs in the intensive, 4 drugs in the continuation phase. Done? Very good. Most of you have got this one. Now it's time for you to check out this question. You have to tell me the important side effect. So deliberately I am going to give you this question. NEET PG में ऐसा question तो नहीं आएगा, but they can ask you the side effect. So just to cover more number of side effect in single question, I have included this kind of question, not to scare any one of you. So okay, tell me Ison Acid or let's say hyperuricemia. Question number 6 question है इसमें. There are 6 questions. Let's say hyperuricemia will be caused by which of the following? Which drug will be causing hyperuricemia given the options that you have? Ison Acid, pyrazinamide, para-aminosalicylic acid, ethambutol and linezolid. Rahul Mukherjee, I was literally going to read you as a Rani Mukherjee, but good thing I read it completely. Yes, so there can be 2 answers here, but out of these 2 also you have to choose the most common. If you have to choose, the answer here can be your प्यार दर्द भी देगा तो pyrazinamide. There can also be one more answer, that is ethambutol, that can also lead to this one. ठीक है, okay. Epileptogenic, which drug can decrease the seizure threshold? I told you Ison Acid can decrease the seizure threshold and it will be epileptogenic in nature. Which drug can cause body secretion discoloration? So I told you if rifampicin is not there, कहाँ पे जाना है? आपने आपका फेवरेट सब्जेक्ट है ना पैथोलॉजी और माइक्रोबायोलॉजी, पास स्टेन सुनते हैं ना, PAS पास स्टेन पढ़ते हैं ना आप लोग, तो जो स्टेन कर दे बॉडी को वो पास होगा, है ना. जस्ट अ वे टू रिमेंबर, जो बॉडी को स्टेन कर दे दैट इज पास, सो दैट इज गोइंग टू बी अगेन सी, बॉडी सिक्रेशन डिस्कलरेशन. विच ऑफ द फॉलोइंग विल बी कॉजिंग बोन मैरो सप्रेशन? In the bone marrow suppression also, the answer to this question will be linezolid. Maximally they will be causing, or more commonly there will be decrease in the platelet count. That is very, very common. Okay, red green color blindness. Red green color blindness, I think this is very, very simple. Optic neuritis is caused by your drug by the name of ethambutol. And hypothyroidism, which drug will be causing hypothyroidism? So 2 drugs that I told you causing hypothyroidism, ethionamide and para-aminosalicylic acid. So among the given choices we are having para-aminosalicylic acid, right? Para-aminosalicylic acid. ठीक है? So this will be everything in this question that we have. Mechanism of action of recently approved agent pritomanid. Pritomanid is a drug, guys. I think all of you guys are aware. Pritomanid, delamanid, manid and manid क्या करते हैं? जल्दी बताइए. Manid and manid inhibit the mycolic acid synthesis. Okay. ATP synthase will be bedaquiline. RNA polymerase inhibitor will be rifampicin. Catalase peroxidase is the enzyme that is required for the activation of Ison Acid. Resistance occurring due to ethambutol is due to mutation of EMB-B gene. This gene encodes for enzyme EMB-B gene. It encodes for an enzyme known as your arabinosyl transferase, because your ethambutol is a arabinosyl transferase enzyme inhibitor, not a catalase peroxidase, because catalase peroxidase के लिए we have CAT-G gene, है ना. Thymidylate synthase will be your THYA gene. RNA polymerase will be your RPOB gene, है ना, RPOB gene. So these are the important one. Thymidylate synthase, do remember it will be inhibited by an enzyme, inhibited by the drug that is para-aminosalicylic acid, and the gene that is encoding this one will be THYA gene. True about chemoprophylaxis of malaria. So for the chemoprophylaxis of malaria, which one is true statement? Long-term prophylaxis, mefloquine 2 day prior, right? This is a wrong statement, not 2 day prior. We are using long-term prophylaxis में 2 week prior. Long-term prophylaxis, mefloquine 2 week prior, yes. And 2 week after, again after the journey, it is used for 4 week. Short-term prophylaxis, doxycycline 2 week prior, right? Short-term prophylaxis, doxycycline 2 week prior, no, 2 day prior. Short-term prophylaxis, doxycycline 2 day prior, yes, and 4 week after. This is the only correct. This was the easy question, but again options are little confusing here. All of the following anti-malarial agent are rapidly acting erythrocytic agent except. So do remember, all are fast acting except pyrimethamine, which is a slow acting. All of the following statements are true about primaquine except primaquine. Active against hepatic stages of all human malarial parasite, yes, that's a true statement. Best agent for dormant hypnocyte, yes, that is why we are using for radical cure. It has high gametocytic property, yes. Highly effective in erythrocytic stage, यहीं पे घंटी बज जानी चाहिए, and you should be able to mark this. No, I told you, no, it's not effective for erythrocytic stage. For the radical cure of the Vivax and oval, primaquine is recommended for single dose on day 1, single dose on day 2, 3-day course of once daily, 14-day course of once daily. So I told you that in the oval and falciparum, oval will be using oval and Vivax we are going to use for 14 days, and falciparum single dose. So again 14-day course. This is radical cure of primaquine. Okay. Fansidar is an approved drug for the malaria, which is a fixed dose combination of artesunate, sulfadoxine, pyrimethamine. We know, so sulfadoxine, pyrimethamine is the correct answer for this one, है ना, sulfadoxine, pyrimethamine. Because artesunate के साथ नहीं, artesunate है ना, artesunate अलग है, sulfadoxine, pyrimethamine उसको हम बोलते हैं फैंसीदार. ठीक है. All of the following are known adverse effect of quinine except, remember, it can cause black water fever, agranulocytosis, QT prolongation, yes. Hyperglycemia will not be there because quinine can increase the insulin release and that can lead to your hypoglycemia. That will be leading to hypoglycemia. Very, very important. So these are the important side effects of quinine, like Synchonism syndrome, that will be characterized by tinnitus, vertigo, visual disturbances, hypersensitivity reaction characterized by rash, urticaria, hematologic like hemolysis, hypoglycemia because of the insulin ka release. Okay. Then they can even cause QT prolongation and black water fever. ठीक है. That there will be black water fever क्यों बोलते हैं? Because in urine में urine will be dark because of the excessive hemolysis and hemoglobinuria, urine will be dark. तो कौन से water की बात कर रहे हैं? Urine की बात कर रहे हैं. Right. So this will be everything which I wanted to quickly cover in our today's session of TB and malaria, and I really hope that all of you guys have enjoyed the session. Sorry for the short disturbances in between, and in the upcoming examination, if there are questions that is going to be asked from these areas, please go ahead, put a smile on your face and mark it very correctly. I'll be able to see you guys in the upcoming session that we have, and before that I'm having a couple of announcement. And what is that announcement? Let me just quickly announce here for all of you guys. So this will be again some announcement about the new subscription that we are having on the platform, new value offerings on the platform. You can unlock 20% off on the platform. You can use the code, the same code that I have already mentioned to all of you guys, that is Pharma10 is one code that you can use. So FMGE Mastery batch, Aspire Next 2023 batch, the duration and the cost has been mentioned here for all of you guys. Aspire Next 2023 is the new batch which is exclusively coming for the next students, and this will be available in the cost mentioned on the screen, and to avail additional benefit you can use the same code, that is Pharma10 that I told you. Final booster batch NEET PG 2023 for 1 month. I think this has already been started. It is already about to finish, but you can watch the recorded session of the same. Crack FMG 23 with FMG Mastery batch. You guys can use this. It has already started on February 10, and the duration will be for 5 months. You can use the same code that I have mentioned, which is Pharma10, to avail some additional benefit in your subscription. Okay. So with this one I will take your leave. I hope you guys have actually enjoyed the session today. Thank you very much for your presence and attendance, and I'll be seeing you guys in upcoming classes that we have. ठीक है, चलो, bye bye to all of you. Have a good day and take care. Thank you to all of you. बंद कर दीजिए।
सर म्यूट कर दीजिए,
हम्म,
माइक म्यूट कर दीजिए।